Sometimes the most impactful scientific insights come from just, well, observing the world around us. Think about those early reports from Jacques Cousteau's divers, the ones living in those underwater habitats. They noticed their minor cuts, scrapes, seemed to heal faster down there, better than back on land.
Right, in that pressurized, oxygen-rich environment, an unexpected observation.
Exactly. But it sparked a really crucial line of scientific inquiry. Because wound healing, fundamentally, it's complex, absolutely essential for survival, obviously.
But sometimes standard approaches just fall short.
They do. Despite everything we know, some wounds just don't heal. They become what we call problem wounds.
And that's where things get challenging.
Welcome to the deep dive. Our mission here is to take source material, maybe an expert chapter, maybe a body of research that you, our listener, have shared, and really act as your guides.
We unpack the evidence, pull out the crucial insights, look at the nuances,
and help you quickly get up to speed on the topic, like having a focused chat with a trusted colleague who's already done the heavy lifting, the dense reading.
And today, we are doing a deep dive into a topic that sits right at that intersection. Those early hyperbaric observations and the modern challenge of treating non-healing wounds, specifically the use of hyperbaric oxygen therapy for selected problem wounds.
It's a therapy with some really fascinating physiological underpinnings.
Oh, absolutely. And a history of, well, varied evidence. Sometimes controversial, it really depends on the specific type of wound you're talking about.
Our source material for this deep dive is a comprehensive expert chapter. It gives a very systematic approach to understanding hyperbaric oxygen therapy in this context.
Yeah, it reviews the core physiology, the specific mechanisms of action, a good chunk of the relevant literature.
And then breaks down the application for multiple distinct problem wound types. Really gets into the clinical details you need.
It's designed to be practical. So over the course of this deep dive, we're going to journey through that systematic approach. We'll start by laying the essential groundwork, the fundamental science of wound healing, and the critical role oxygen plays in that whole intricate cascade.
Then we'll move into how hyperbaric oxygen therapy specifically influences these processes, at the cellular level, tissue level, even systemically.
Right. And the bulk of our time, which reflects the focus in the source material and where the evidence really lies, will be dedicated to reviewing the literature and the clinical considerations for hyperbaric oxygen therapy in various specific problem wound categories.
That includes diabetic foot ulcers, which, as the source makes clear, have really become the dominant focus.
Yeah, largely driven by patient prevalence and, frankly, reimbursement availability.
But we won't stop there. We'll also look at arterial insufficiency ulcers, calciphylaxis, that rare but severe condition.
Graft versus host disease wounds, venous stasis ulcers.
Those challenging digital ulcers in scleroderma and Raynaud's, sickle cell ulcers, and pyoderma gangrenosum.
And for each one, we'll follow the same structure. Look at the underlying pathophysiology, the specific rationale for using hyperbaric oxygen, what the literature actually says, or doesn't say.
Considerations for patient selection, treatment protocols, and we'll briefly touch on cost-benefit and utilization review as our source presents it.
This deep dive is really structured to help you, the listener, navigate all this evidence and understand where hyperbaric oxygen therapy might fit or where it might not fit within the broader management of these complex patients.
Okay, let's start by unpacking that historical context that really set the stage.
Sounds good. Let's delve into that history as the source recounts it.
It begins with that intriguing story. Jacques Cousteau's Conshelf 2 experiment back in the 60s. Red Sea. Divers living underwater, increased pressure, specific gas mix.
And the anecdotal reports started coming back. Minor injuries, cuts, scrapes, they seemed to heal remarkably well compared to surface injuries.
Anecdotal, sure, not rigorous science yet. But compelling enough that in 1964, the National Science Foundation tasked Dr. T.K. Hunt, a real pioneer in wound healing research, with investigating these claims.
And Dr. Hunt's work, along with his colleagues, was absolutely foundational. They moved beyond the anecdote. They helped establish the robust scientific evidence demonstrating that wound healing is profoundly dependent on adequate tissue oxygenation.
That understanding that oxygen isn't just passive, it's actively needed, was the crucial scientific underpinning.
Exactly. It spurred interest in therapies that could actually enhance oxygen supply to injured tissues. Really set the stage for exploring hyperbaric oxygen therapy in wound care.
It's interesting, though, how that initial broad interest seems to have narrowed over time. The source points out that recently, clinical application for wound healing has become heavily focused almost exclusively on the diabetic foot ulcer.
That concentration is understandable, even if it perhaps limits broader exploration. The reasons are quite pragmatic, as the source notes.
High prevalence, for one.
Absolutely. Diabetic foot ulcers are a massive global clinical and public health burden. And second, critically for adoption, is the availability of specific reimbursement for treating diabetic foot ulcers with hyperbaric oxygen, particularly under systems like Medicare in the U.S.
Right. High patient volume plus financial support naturally directs research, practice, reimbursement discussions towards that specific wound type.
But the source is careful. It doesn't suggest that diabetic foot ulcers are the only wounds that might benefit. It states clearly there are sound fundamental reasons why giving extra oxygen might help other non-diabetic foot wounds too.
That's a really important point, and it leads to the central challenge the source presents, the reason we need this systematic approach.
Right. Based on Hunt's work showing healing needs minimum oxygen levels, it's easy to extrapolate, logically it seems. If some oxygen is good, more oxygen via hyperbaric therapy should improve healing in any hypoxic wound.
But the challenge is determining if there's actual specific evidence to support that extrapolation for all the different kinds of problem wounds we see.
Exactly. Which brings us to the question the source poses. A problem wound fails to heal, but what specific characteristics or diagnoses make hyperbaric oxygen therapy acceptable, evidence-supported, for some problem wounds but not others?
And that's why the source provides this systematic approach, our roadmap for this deep dive.
Precisely. This systematic approach helps cut through the complexity, aiming for informed clinical decisions. First, review basic physiology of wound healing, oxygen's role. Second, look at tools to measure tissue oxygenation, normobaric and hyperbaric.
Third, explore the specific biological mechanisms of hyperbaric oxygen therapy.
And finally, the biggest section, a detailed, evidence-based breakdown of multiple specific problem wound types, using a consistent format for each. Pathophysiology, rationale for hyperbaric oxygen, literature review, patient selection, protocols, cost-benefit, utilization review.
The structure empowers you, the clinician, to assess the evidence for a specific patient. Let's start by digging into that fundamental physiology.
Okay, the foundational role of oxygen in wound healing.
It's not just helpful, it's critical. A necessary cofactor for so many cellular processes essential for successful healing.
The source pinpoints several specific oxygen-sensitive processes, things like fibroblast replication, those cells laying down the new tissue matrix.
Collagen deposition itself for structural integrity.
Angiogenesis, forming new blood vessels to bring nutrients, immune cells, more oxygen.
Resistance to bacterial infection.
And that critical process of intracellular killing of bacteria by leukocytes, a key immune function right in the wound bed. All these vital steps heavily depend on having enough oxygen locally.
So oxygen is a necessity. What about when tissue lacks it, when it's hypoxic? The source describes hypoxia not just as a deficit, but as a fundamental driver initiating the healing cascade.
That's a key paradox, isn't it? Hypoxia, low oxygen, acts as a signal. It triggers biological processes aimed at adaptation, survival in that low oxygen state.
Hypoxia-inducible factors, HIFs, are central here.
Absolutely central. They're transcription factors that become stable, active under hypoxia. They essentially reprogram cellular activity. This hypoxic adaptation cascade involves stimulating angiogenesis to improve blood supply,
Promoting anaerobic glycolysis for energy without oxygen.
influencing growth factor signaling, enhancing cell mobility so cells can get to the wound.
Even stimulating red blood cell production, erythropoiesis, to potentially boost systemic oxygen delivery.
So hypoxia kicks things off, but paradoxically, healing needs oxygen to finish the job.
Okay, how does oxygen actually get to the wound tissue then to fuel these processes?
Well, delivery is a multi-factor process. Cardiopulmonary system, circulatory system. It's determined by three main things. Cardiac output, how much blood the heart pumps.
Peripheral vascular resistance affecting blood flow distribution.
And oxygen saturation of the blood, mostly how much oxygen is bound to hemoglobin.
And under normal conditions, the oxygen just dissolved in plasma is pretty minimal.
Right, the source calls it inconsequential for meeting metabolic domains normally. So normal oxygen delivery relies heavily on that hemoglobin dissociation curve, how readily hemoglobin picks up oxygen in the lungs and drops it off in the tissues based on local oxygen pressure.
Since intact skin is a barrier, it's the cardiopulmonary system getting oxygenated blood deep to the dermis and subcutaneous tissues.
That's the main route. And the source notes, while oxygen carrying capacity relates to hemoglobin, anemia alone doesn't inherently stop wound healing. Other factors are often more critical.
So what is the most important factor for healing potential?
The source emphasizes the arterial partial pressure of oxygen, the arterial PO2. That value, and thus tissue oxygen delivery, can be modulated by things like vasodilation, better cardiac output, changes in capillary permeability, all influencing how much oxygenated blood flows into the wound.
Let's walk through the specific phases of wound healing and pinpoint the oxygen needs at each step, based on the source.
Starting with hemostasis. Hemostasis, the immediate response. Focus is stopping blood loss. Vasoconstriction, platelet aggregation forming a plug, fibrin clot formation.
Platelets release growth factors, too, attracting other cells.
Right. Though in chronic wounds, the source notes, controlling ongoing drainage from inflammation and edema is often more the issue than stopping acute bleeding.
Then comes inflammation. This seems highly oxygen-dependent.
It absolutely is. Inflammation kicks off quickly. Migration of neutrophils, monocytes, fibroblasts, endothelial cells to the site.
Their job is clearing debris, fighting microbes.
Initially, yes. Monocytes become macrophages. They're key players then. Tissue debridement, bacterial killing, secreting cytokines and growth factors to signal the transition to the next phase, the proliferative phase.
The source mentions oxidative versus non-oxidative bacterial killing by leukocytes.
An important distinction. Oxidative killing uses reactive oxygen species, ROS. It's the main defense against common wound bacteria. Non-oxidative is less potent, more for less virulent species, or maybe more relevant in immune-suppressed patients.
And neutrophil killing requires oxygen.
Critically, it's energy-dependent, needs glucose, and oxygen-dependent. Atmospheric oxygen is essential for producing those bactericidal intermediates, especially hydrogen peroxide. Neutrophils use an oxygen-dependent respiratory burst, converting oxygen to superoxide. Phagocytosis triggers this, causing a huge jump in oxygen consumption, 20 to 100-fold increase.
And the source gives specific data correlating local PO2 with neutrophil efficiency. This seems like a key takeaway number.
It is one of those crucial thresholds. The source notes that as tissue PO2 drops from normal, say 60 millimilli Hg, down to 0.10 millimilli Hg, that correlates with neutrophils rushing in. But this effect is reduced if the wound is already ischemic. For actual superoxide production, half maximal rate is between 80 to 150 millimilli Hg, maximal rate over 300 millimilli Hg.
But here's the critical part for efficient killing.
Yes. The source states that efficient phagocyte bacterial killing requires a local tissue PO2 of 30 millimilli Hg or greater.
30 millimilli Hg.
Yep. The experiments cited are compelling. Neutrophils cultured with zero oxygen killed 37% of bacteria. At 5 millimilli Hg, 58%. At 30 millimilli Hg, 70%. Going up to 150 millimilli Hg only gave minor increases, so 30 millimilli Hg seems to be that key functional threshold for efficient immune killing.
The source also mentions oxygen levels impacting infection spread.
Yes, combining early antibiotics with hyperoxia elevated oxygen leads to more efficient bacterial clearance than delayed antibiotics or oxygen alone. Increased inspired oxygen has also been shown to decrease the spread of infectious necrosis and boost bacterial clearance.
Moving to the proliferative phase, building new tissue, the source says all key functions here relate directly to wound PO2.
Absolutely. Collagen deposition, angiogenesis, new blood vessels, granulation tissue formation, epithelialization, skin closure, all highly oxygen dependent.
Wound PO2 drops during this phase.
Right. Initially, it might be near arterial levels, but it drops as small vessels thrombose and oxygen-hungry cells like leukocytes and fibroblasts increase. A proliferating wound has a very high metabolic oxygen demand. That's why tissue PO2 is often depressed post-surgery.
In fibroblast activity, collagen synthesis directly tied to oxygen.
Directly. Decreased fibroblast activity from low oxygen means less collagen deposition, slower healing. And here's another crucial biochemical detail and number from the source. Collagen synthesis requires hydroxylation. This step inserts an oxygen atom from dissolved oxygen in the tissue using the enzyme protel hydroxylase. Collagen cannot be saved without oxygen.
And a key number.
The Michaelis constant, the K-lam of oxygen for this step is 25 milliAg tissue oxygenation. Collagen deposition significantly decreases.
Okay, two critical thresholds memorized. 30 millimeter G for immune killing, 25 millimeter H for collagen synthesis.
Those are the core physiological requirements highlighted. And even the quality of collagen depends on oxygen. Tensile strength increases with high PO2, decreases with high PCO2.
Angiogenesis too.
High oxygen stimulates angiogenesis. Neovascularization, both angiogenesis and vasculogenesis from circulating precursors, is increased by hyperoxia. HIF-1 is thought to help guide those circulating stem progenitor cells, SPCs, to ischemic tissue.
Epithelialization.
Increases with hyperoxia, decreases with hypoxia, accelerates by about 30% with high oxygen, though wound contraction seems independent of oxygen levels.
Finally, remodeling.
The longest phase, weeks to months after closure, newly deposited collagen gets reorganized into a stronger lattice. Initial collagen is thinner, less organized. Strength increases over 4 to 5 weeks with more collagen and cross-linking, but even then, it's fragile.
The source gave numbers for strength recovery.
Yeah, sobering numbers. Only about 3% strength at 1 week, 20% at 3 weeks, maybe 80% at 3 months. It never reaches 100% of uninjured tissue strength. Ultimate strength depends on the quantity and quality of that collagen laid down during the oxygen-dependent proliferative phase.
So to summarize the physiology,
the source emphasizes, hypoxia initiates the cascade via HIF stabilization and gene transcription. This drives cell migration, but these cells consume oxygen, lowering already low levels. The wound oxygen extraction fraction is high, about 0.7, 1.0 vol%. And this extraction rises with increased oxygen breathing evidence. The oxygenase enzymes ramp up activity when more substrate is available.
And that interesting idea about intermittent oxygen.
Yeah, the hypothesis that intermittent hypoxia might stimulate a latent capacity for collagen synthesis, which is then fulfilled during periods of normoxia with better energy supply. It hints at the potential value of the cyclic hyperoxia and normoxia from intermittent hyperbaric treatments.
Okay, solid foundation on oxygen, the vital role, those key thresholds. Now, back to the core question. How do we define which problem wounds are good candidates for hyperbaric oxygen therapy?
The source reiterates. Tissue hypoxia is often the final common pathway to PER healing. So any non-healing wound could potentially benefit from hyperoxia if it's objectively shown to be hypoxic.
Logically, you'd hope proving hypoxia would qualify it for treatment.
That would be the hope. But the source notes clinical practice hasn't always aligned perfectly with that.
Which brings us to objective assessment. How do we actually measure tissue oxygenation and perfusion?
The source outlines available tests, dividing them. Macrovascular, looking at larger vessels, and microvascular, assessing the tissue bed itself.
Macrovascular includes things like ABI, PVRs, Doppler.
Right. Ankle brachial index, pulse volume recordings, arterial Doppler, CT or MR angiography, conventional angiography. These assess the main supply line.
And microvascular, more relevant to the wound bed itself.
Often, yes. Tools here include skin perfusion pressure, SPP, transcutaneous oxygen measurement, TCOM or TCPO2, and indocyanine green fluorescence angiography, ICGA. These estimate how well oxygenated blood is actually reaching the skin and subcutaneous tissue.
Let's focus on transcutaneous oxygen measurement, TCPO2. The source gives it significant weight.
It does. TCPO2 is presented as a key objective tool. It measures oxygen pressure through intact skin using heated electrodes, usually placed adjacent to the wound, periwound, and a control site like the chest.
And these values have prognostic power, predicting healing and response to hyperbaric oxygen.
Exactly. The source provides specific thresholds and probabilities from the literature. Breathing room air. TCPO2 40 millimole H is defined as hypoxic, reduced likelihood of healing. Breathing 100% normobaric oxygen. TCPO2 35 millimole Hg under this condition is linked to a 41% failure rate with subsequent hyperbaric oxygen therapy. Breathing 100% normobaric oxygen. But if a wound is hypoxic on room air, 40 millimole A&D, the TCPO2 increases while breathing 100% normobaric oxygen to 35 millimole A&D represents 50% increase from the air value. Those wounds are considered likely to benefit from hyperbaric oxygen therapy, about a 69% chance of beneficial response.
And the source identifies in-chamber TCPO2 as the most valuable predictor.
Yes, measuring TCPO2 while the patient is inside the hyperbaric chamber under pressure is stated as the single most valuable predictor of response. Specific values correlate strongly with outcomes.
What are those values?
In-chamber TCPO2 between 200-299 millihg and higher are linked to significantly reduced failure rates. Specifically, a value greater than 200 mmHg suggests an 84% likelihood of benefit from hyperbaric oxygen therapy.
And below 100 mmHg?
Only a 14% likelihood of benefit. These numbers provide strong objective data for patient selection.
But the source adds a nuance. TCPO2 shouldn't be the only factor.
Crucial clinical context. While TCPO2 gives objective evidence of local hypoxia and responsiveness, selection involves more. Hyperbaric oxygen has systemic effects stimulating neovasculogenesis, mobilizing endothelial progenitor stem cells that a local reading doesn't capture.
So, Objective evidence of hypoxia should be used, but clinical judgment matters too.
Absolutely. Considering potential systemic benefits and the overall clinical picture is necessary.
The source also discusses using in-chamber TCPO2 to optimize treatment pressure.
A practical application. It can provide objective data to guide choosing the best pressure for an individual. The source highlights a study by Haber et al. Using a 250 mmHg cutoff for response in lower extremity wounds.
What did they find?
Almost 80% of patients hit 250 mmHg at 2.0 ATA. But importantly, among those who didn't reach 250 at 2.0 ATA, nearly half, 41%, did get above 250 mmHg when pressure increased to 2.4 ATA.
That directly informs planning.
It does. It allows a potentially objective choice of treatment pressure to maximize benefit while using the lowest effective pressure, minimizing risk.
Are there other assessment methods mentioned?
Yes, indocyanine green fluorescence angiography, ICGA, mentioned as promising. Inject dye, use near-infrared camera to visualize microvascular perfusion in real time. Used by surgeons, recent reports in hyperbaric patients with radionecrosis or chronic wounds.
But still somewhat investigational for guiding hyperbaric decisions.
Based on the experience cited, the source notes more work is needed to determine specific clinical decision-making parameters around ICGA for hyperbaric therapy. Not as established as TCPO2 yet for this specific purpose.
Okay, that covers physiology and objective assessment. Let's quickly recap the absolute essentials before we move into HBO mechanisms in the literature.
Let's consolidate. Oxygen is vital fuel. Critical processes need it. Remember, 30 mmHg tissue PO2 for efficient immune killing, 25 mmHg for optimal collagen synthesis. Hypoxia initiates, but healing demands oxygen, often creating a local deficit. Objective measures matter, especially transcutaneous oxygen measurement, TCPO2. It predicts response, particularly in chamber at pressure, where values over 200 mmHg correlate strongly with success. This groundwork helps us understand how hyperbaric oxygen therapy aims to address these needs.
Excellent recap. Now let's dive deeper into the specific mechanisms of hyperbaric oxygen therapy. It's more than just giving oxygen in a chamber, right?
Absolutely. The most obvious mechanism is delivering significantly increased oxygen to ischemic wounds. This follows Henry's law. Gas dissolved in liquid is proportional to the partial pressure above it.
So breathing 100% oxygen under pressure drives much more oxygen into the plasma.
Dramatically more. The source illustrates breathing 100% oxygen at 3 ATA can theoretically dissolve enough oxygen in plasma alone to meet metabolic demands without hemoglobin. We don't usually use 3 ATA for wounds, but at the common 2.0, 2.5 ATA.
The increased dissolved oxygen significantly boosts diffusion distance.
By a tenfold increase, the source says, effectively loading skin and subcutaneous tissue with supernormal levels of oxygen. Arterial PO2 can exceed 1,500 mmHg, leading to high tissue oxygen levels. This temporary hyperoxygenation provides the needed substrate, the fuel, for healing in previously starved tissues.
But you said it's not just about oxygen saturation, other benefits under hyperbaric conditions.
Yes, and this is key to why it offers advantages over just 100% oxygen at normal pressure. Beyond oxygen delivery, hyperbaric conditions provide other therapeutic effects.
Like what?
Ameliorating ischemia or reperfusion injury, stimulating circulating stem progenitor cells, augmenting neutrophil bacterial killing activity, remember that 30 mmHg need, and influencing the production of reactive oxygen and nitrogen species, which act as signaling molecules.
Let's talk about those reactive oxygen and nitrogen species, ROS and RNS, often seen negatively, but here they're important signals.
Correct. In appropriate amounts and places, they influence growth factors, cytokines, hormones involved in healing. ROS examples: superoxide, hydrogen peroxide; RNS, nitric oxide, NO, peroxynitrate. 3 main NO synthase enzymes produce NO.
It's a balance.
Yes. High levels cause damage. Oxidative stress, a problem in chronic wounds due to overproduction. But the body has antioxidant defenses. The source clarifies that the oxidative stress from intermittent hyperbaric exposure is different, generally well handled by these defenses.
And how does hyperbaric oxygen help with ischemia reperfusion injury?
That's the damage when blood flow returns after ischemia, causing inflammation. Hyperbaric oxygen therapy inhibits neutrophils sticking to the vascular endothelium, reducing this inflammatory response and edema.
Importantly, without harming their bug-killing ability.
Right. It does not inhibit their crucial antimicrobial functions like degranulation, phagocytosis, or the respiratory burst.
Stimulating circulating stem progenitor cells, that's fascinating.
It is. It points to promoting new vessel formation, vasculogenesis, from these circulating precursors, not just angiogenesis from existing vessels. Tom's work showed HBO can mobilize these stem progenitor cells, SPCs, from bone marrow.
A single exposure doubles them. 20 sessions, an 8-fold increase.
Impressive numbers. Tom also linked this to increased stem cell HIF content in diabetics, possibly explaining improved healing via HIF-1 guiding cells to ischemic tissue. But the source acknowledges conflicting findings, too. Understanding HIF-HBO interaction is incomplete.
Beyond cells, the source lists growth factors and mentioned gene regulation being affected.
That's right. HBO increases synthesis of a wide range of key growth factors and receptors: VEGF, HIF-1 alpha, BFGF, TGFR1, angiopoietin-2, MMP2, MMP9, TIMB1, PDGF receptors. This links directly to better extracellular matrix production, collagen synthesis.
Epithelialization accelerates too.
By about 30%. Wound contraction seems independent. Boykin et al. Found increased nitric oxide in diabetic ulcer fluid correlated with better granulation and healing after HBO.
And the gene regulation finding.
Striking. Over 8,000 genes and chaperones in microvascular cell cultures showed up or down regulation with hyperbaric oxygen. This effect was not seen with 100% oxygen at 1 ATA, underscores the unique effects of the hyperbaric environment itself.
The source uses an analogy to tie these mechanisms together.
A vivid one. Wound healing needs oxygen fuel. Without it, the engine stalls. Hypoxia initiates the cascade. Hyperbaric oxygen isn't just fuel, it's a turbocharged boost, like nitrous oxide, NOS, for a race car.
And the intermittent nature is like pumping a swing.
Exactly. Intermittent hyperoxy-oxidative stress followed by relative hypoxia acts like that pumping action, building momentum, driving the wound towards healing.
That makes it much more tangible.
Okay.
Essential foundation built. Physiology, assessment, HBO mechanisms. Now let's apply this to specific problem wounds, starting with the big one. Diabetic foot ulcers.
Diabetic foot ulcers, DFUs. Most common, most studied. Complex pathophysiology, multi-organ dysfunction from hyperglycemia.
Cellular effect.
Certain cells can't downregulate glucose transport. Leads to chronic superoxide increase, suppresses endothelial nitric oxide synthase, ENOS, a vasodilator. Result, vasoconstriction, peripheral hypoxia.
Basement membrane thickening too.
Yes, reducing oxygen diffusion. Also decreased bone marrow ENOS activity, impairing SBC mobilization. Repression of HIF-1 production.
And neuropathy is huge.
Responsible for the majority of diabetic foot pathology. Autonomic neuropathy reduces the hyperemic response to injury functional ischemia on top of anatomical issues. Motor neuropathy causes deformities, clawfoot, hammer toes, Charcot, creating pressure points.
Sensory neuropathy means they don't feel injuries.
Exactly. Allows ulcers to develop unnoticed. Dermatologic changes from autonomic neuropathy, dry, cracked, calloused skin offer entry for bacteria. Increased pressure from callus plus sensory loss. A deadly combination initiating the ulcer.
Given this environment prone to hypoxia and poor healing, what's the specific rationale for using hyperbaric oxygen in DFUs?
Very strong rationale. HBO directly addresses many deficiencies. DFUs are often profoundly hypoxic, prone to infection. HBO delivers oxygen at high pressure, increasing arterial PO2 and plasma concentration, driving oxygen into hypoxic tissue.
Providing fuel to overcome microangiopathy.
Yes, and promoting neovascularization, collagen deposition. It specifically counteracts diabetic issues like local microangiopathy and impaired SPC mobilization. Stimulates growth factors, VEGF, FGF, TGF-beta, NO, PDGF.
Systemically.
Stimulates bone marrow SPC mobilization via ENOS, increasing nitric oxide without needing the deficient cytokinin receptor complex in diabetics. Combined with HIF-1 alpha effects, this elevates circulating SPCs, improves homing, promotes de novo neovasculogenesis, increases collagen, better granulation, better healing. It targets multiple failure points.
Compelling rationale. Let's look at the extensive DFU literature, starting with early studies.
First published report, Hart and Strauss, 1979. Retrospective, 11 DFUs among 35 refractory ulcers. Reported 73% improved, 18% healed. Limitations. No severity, no protocol details mentioned.
And then Davis et al. In 87.
Focused specifically on DFUs. Case series, 168 patients. Reported 70% healing, 30% major amputation, 70% limb salvage. Again, no control group, no severity info. Importantly, they recognized prioritizing revascularization, recommended HBO post-revascularization, noted it was usually futile in elderly diabetics with large vessel occlusion not fixable, underscores need for blood flow.
This concept of limb salvage was a major focus of those early Italian studies.
Yes, a prominent series provided early insights into limb salvage. Baroni et al., 1987, prospective study, 28 hospitalized patients, mostly gangrene, Wagner 4. 18 got HBO, 10 controls, decline therapy. 2.5, 2.8 ATA, 90 minutes, average 34 treatments. Results were striking. HBO group, 89% healing versus 10% control, P 0.001. Major amputation, 11%. HBO versus 40% control, PP 0.001. Faster healing, too. They theorized microcirculation issues even with normal large vessels. Their historical amputation rate dropped from 40% pre-HBO to 8.4% with HBO. Oriani et al., 1982 retrospective. 80 hospitalized patients, advanced ulcers gangrene. Similar protocol, average 72 treatments. Part of strict multidisciplinary care, long admission, glycemic control, aggressive debridement, antibiotics. Results, 95% healing HBO versus 67% control. 5% major amputation HBO versus 33% control, P 0.001 both. Their updated limb salvage stats showed 4.8% AKA with HBO versus 33% non-HBO 1983-87. Yeah. Their 10-year experience. Defined limb salvage broadly included successful TMA. Reported 86% success if completed 12 sessions. Promoted tenets still valid. Use early multidisciplinary team periodic reevaluation. Pioneers in recommending stopping if no objective improvement.
That series really built the case for severe DFUs and the team approach. Let's take a quick micro recap before the first randomized controlled trials.
Okay, quick pause. We've established oxygen's vital role, remember 30 mmHg immune killing, 25 mmHg collagen synthesis. Explored HBO's turbo boost mechanisms beyond just oxygen delivery, ischemia, reperfusion, stem cells, growth factors. Saw early DFU studies, especially the foundational Italian series, demonstrating potential for healing and, crucially, limb salvage in severe cases, emphasizing multidisciplinary care and stopping if no response. Now, let's see how randomized controlled trials change the picture.
Moving to randomized controlled trials, the source starts with Dr. et al., 1992.
Significant as the first reported randomized trial, though its protocol was unusual. 30 hospitalized patients, chronic DFUs, some gangrene, severity enrollment details lacking, vascular status by pulses only, non-standard protocol, 3 ATA, 100% oxygen, only 45 minutes, total 4 treatments over 2 weeks.
Just 4 treatments.
Very brief. Despite that, reported major amputation rate 13% HBO versus 47% control P 0.05. Also decreased positive wound cultures. Source notes the study, despite odd design, showed efficacy and raised the question, is a long course mandatory or can a short post-surgery course work? Still debated.
Thalia et al., 1996, is highlighted as pivotal.
A landmark study. Non-blinded RCT, 68 hospitalized patients. Included Wagner 3 or 4 immediately, or Wagner 2 if large infected failed 30 days outpatient protocol. 2.2, 2.5 ATA, 90 mins mean 38 treatments. Critical aspect. Aggressive pre-HBO revascularization. Yet post-revasc, both groups still showed PAD and hypoxia, mean ABI, 0.65, TCPO2, 22 mmHg.
Key takeaways from Thalia.
Source points out, underscored importance of revascularization and glycemic control. Crucially, it included vasculopaths often excluded elsewhere, showing effectiveness even in the ischemic hypoxic diabetic foot.
Results. Impactful. Reduced major amputations. 9% HBO versus 33% control, P 12.002. Increased tissue oxygenation. TCPO2 increased 14 mmHg HBO versus 5 mmHg control, P 0.002. For Wagner 4 specifically, 9.1% amputation HBO versus 55% control, P 0.002. But source notes no statistically significant difference for Wagner 2 or 3 ulcers in this study.
And this study had impact beyond the literature.
Huge impact. First to explicitly report using Wagner classification, CMS considered it the pivotal study leading to approving hyperbaric oxygen coverage for DFUs in the U.S.
But CMS criteria differ from Faglia's protocol.
Right. Faglia treated Wagner 34 immediately. CMS criteria, as of 2018, require Wagner 3+ and failure of 30-day standard care. Source also mentions criticisms of Wagner scale itself, but its importance here is tied to this paper influencing CMS policy.
After these initial trials, focus shifted to defining selection criteria. Yes, recognizing unequal responses, researchers sought predictors. Wathell et al., 1991, case series, 59 HBO-treated DFUs, 81.4% healing, 18.6% amputation.
Yeah.
Key finding. The only factor linked to healing was wound TCPO2 while breathing oxygen under pressure, the in-chamber TCPO2. Significantly higher in healed, 786 mmHg versus not healed, 323 mmHg, P 0.005. Thalia et al., 1998 retrospective cohort, showed HBO's independent protective role against major amputation, 14% and 31%. Identified predictors like Wagner Grade, TCPO2. Importantly, tracked decreasing amputation rates over time despite sicker patients, attributing improvements significantly to their dedicated multidisciplinary foot team and clinic. Reinforces the system of care aspect.
Pfeiffer's work further clarified using oxygen measurements.
Yes, 2002 and 2007 case series. 2002 study, 774 patients. In-chamber TCPO2, 200 mmHg was best single discriminator for predicting healing, 74% reliability. 100 mmHg meant low likelihood. 2007 study, 971 patients corroborated, 84% response rate of 200 mmHg, only 14% if 100 mmHg. Also identified factors impacting outcome. Renal failure, smoking, treatment completion. Strauss's 2002 work mirrored Fife. TCPO2 200 mmHg under hyperbaric conditions defined responders with high sensitivity specificity. Combined Fife-Strauss data confirmed nearly 90% of DFUs with TCPO2 200 mmHg healed, led to UHMS publishing a clinical practice guideline in 2009 on using TCPO2 for prediction.
What about studies on chronic, maybe less severe ulcers?
Kalani et al., 2001. Prospective cohort, 38 patients, chronic DFUs, 2 months. Likely Wagner 1 or 2, excluded deep infection green. Incomplete randomization lacked statistical significance at 3 years. 76% healing HBO versus 48% control. 12% major amputation HBO versus 33% control. But only difference found was in chamber TCPO2. Higher in healed, 234 mmHg versus amputated, 142 mmHg. Consistent with Fife-Strauss, so not statistically significant here. Source concludes, suggests possible help for hypoxic Wagner 12, but evidence less strong than for severe cases.
That's a detailed look at the evolution early promise, identifying predictors like TCPO2, influencing coverage. Let's take another micro recap before recent trials.
Okay, charting the DFU evidence journey. From early case series and Italian studies showing limb salvage potential and need for multidisciplinary teams, to the first randomized trials like Dr. et al., raising protocol questions, and the pivotal Faglia study, influencing CMS, showing benefit in severe Wagner 3+. Critically, subsequent work by Waddell, Fife, Strauss established in-chamber TCPO2 200 mmHg as a strong predictor of response. Evidence for milder Wagner 12 is less definitive. This phase highlighted selecting patients most likely to benefit. Now, let's examine more recent trials, including rigorous designs and the hooded ones.
Moving into recent randomized controlled trials, the source notes a trend. More rigorous methodology, but often a different patient type chronic, less acutely ill.
An important shift. Recent studies often use double-blinding, sham controls, but typically include patients with chronic ulcers, present weeks or months, failed prior care. Often stable outpatients, distinct from acutely hospitalized patients in some early trials.
Abidia et al., 2003, first double-blind placebo-controlled study.
Yes, though small, 18 patients. Included Wagner 12, failed 6 weeks with Piracol. 30 treatments, HBO, 100% O 2.4 ATA 90 minutes versus sham, air 2.4 ATA 90 minutes. No difference at 6 weeks, but key finding. Significant difference at 1-year follow-up. Healing rate 63%, HBO versus 0% control, PA 0.027. Provided level 1 evidence, limited by size, suggesting persistent benefit, supporting the idea HBO initiates healing that continues.
Kessler et al., 2003.
Unblinded RCT, 27 patients, chronic Wagner 1 through 3, excluded significant PABI, high intensity, short protocol, 20 HBO treatments, 2.5 ATA BAD, over 2 weeks hospitalized, showed significantly larger wound size reduction at discharge, PO 0.037, but difference lost by 4-week follow-up. No significant difference in healing amputation rates. Criticized for short follow-up. Maybe early gains lost as post-discharge care offloading inadequate.
Gun et al., 2006 larger study.
Yes, unblinded RCT, 100 patients, Wagner 2 to 4 failing 4 weeks care, used modified Wagner, 20-30 HBO treatments, 2 to 3 ATA. Reported significantly higher healing without surgery, 66% reads 0%. Fewer major amputations, 0%, 0.34%. Fewer minor amputations, 8%, 0 status, 48%. In HBO group, all P.05. Source notes potential selection bias, unblinded surgeon decided amputation, and unusual healing definition. Estimates more realistic healing rate, 74%, HBO versus 18% control.
Landau et al., 2010 highlighted as rigorous.
Yes, randomized, double-blinded, sham-controlled trial. 75 patients, chronic Wagner, 2 to 4, 3 months. Up to 40 treatments, HBO on prep, O 2.5, ATA 90 mins versus sham error, 2.03, NNT 4.2. Per protocol, 35 treatments. Even higher healing, 61%, TSPS 27%, P.009, NNT 3.1. No significant difference in major amputation. Importantly, showed strong correlation. Baseline TCPO2 predicted healing after HBO. 25 mmHg, 0% healed, 2650, 50%, 5175, 73%, the testing 500%. Reinforced objective measures. Follow-up showed improved quality of life, SF36 at 12 months.
Okay, another micro recap, focusing on contributions of these recent trials.
These recent RCTs, often more rigorous, double-blind, sham-controlled, added crucial layers. Abidia provided the first level 1 evidence, showing significant, durable 1-year healing benefit, suggesting lasting repair initiation. Lundahl, also vigorous, confirmed improved 1-year healing and gave compelling data on baseline TCPO2's predictive value for responders. While some unblinded studies showed dramatic amputation reductions, they highlighted challenges like bias and variable outcome definitions. These trials, often on more stable chronic patients, reinforce HBO as adjunctive and stress proper selection and treatment adherence.
Now let's look at studies presenting evidence against widespread use or raising significant questions, starting with Margolis et al., 2013.
A notable study, very large longitudinal observational cohort, 6,259 patients. Plantar DFUs, 40% healing at 4 weeks. Use clinical database data, propensity scoring. Source says it called into question HBO effectiveness in real-world practice.
But criticisms of methodology.
Significant ones detailed by the source. Issues with the database. Assuming strict guideline adherence, called erroneous, undefined terms, adequate perfusion, standard care. Importantly, included many patients, 54.3% getting HBO or Wagner 2, likely ineligible per CMS criteria, potentially biasing towards less severe ulcers.
The results were counterintuitive.
Compared to RCTs, yes. At 16 weeks, HBO group had lower healing, 42.3%, HAS 49.6%, higher overall amputation, 6.7% is 2.1%, higher major amputation, 3.3%, ACE is 0.3%. Hazard ratios reflected this. Higher amputation risk, 2.37. Lower healing likelihood, 0.68 with HBO. Even in Wagner 3 plus ADOS, amputation HR higher 1.41 with HBO.
Methodological discussion.
Source notes HBO group naturally had more severe ulcers. 45.7% Wagner 3 to 5 versus 18.4%, which propensity scoring aimed to fix, maybe imperfectly. Margolis clarified it studied effectiveness, real-world versus efficacy trials.
Takeaway lesson.
Crucial one, per the source. Strongly emphasizes importance of proper patient selection. Cautions against indiscriminate HBO use. Suggests overuse in patients who won't benefit, would heal anyway, or lack adequate standard care first, leading to poor outcomes in broad, unselected populations.
Another study generating discussion. Fedorko et al., 2016.
Double-blinded, placebo-controlled RCT on 107 patients. Wagner 2 for 4 DFUs, 4 weeks. Excluded Revas candidates. Protocol. 30 treatments. HBO 100%, O2 2.4 ATA versus sham air 1.2 ATA. Only 61% of HBO group completed all 30.
Primary endpoint was controversial.
Highly. Not actual amputation rates, but reducing predefined indications for amputation. Lack of progress, deep infection, etc. Critically, these indications were decided only by chart review and photos, no physical exam. Reported no difference in meeting these criteria, 22.4% HBO versus 24% control.
Criticisms and takeaway.
Significant criticism post-publication. No actual amputation rates. Surrogate endpoint allegations of irregularities.
Yes.
Source takeaway. Study suggests hyperbaric oxygen therapy may potentially be overused in DFUs. Fedorko acknowledged a subset might benefit, but recommended against general use until that subset is better defined.
Asamala, 2018, also touched on adherence challenges.
Multicenter RCT, Netherlands. 120 patients. Wagner 2-4 DFUs with limb ischemia. HBO plus standard care versus standard care alone. Assessed for Revasc first. Prescribed 30 HBO sessions, 2.4, 2.5 ATA. Intention to treat at 12 months. No significant difference in healing, limb salvage, or amputation-free survival.
But per protocol analysis differed.
Yes. Patients who completed the 30 HBO sessions had significantly better outcomes. Fewer major amputations, fiber FANCID 22% control, higher amputation-free survival. NNT was 6 for major amputation prevention in this compliance subset.
Non-completion was high.
35% of the HBO group didn't complete protocol. Declined, healed early, medical issues, etc. Source mentions criticism that design allowed unwilling patients, diluting ITT analysis. Important takeaway. Reinforces proper patient selection, including likelihood of completing demanding therapy, is critical. Advanced morbidity may prevent completion, affecting real-world effectiveness.
These studies certainly add complexity, highlighting challenges translating efficacy to effectiveness. Let's take another micro recap here.
We've navigated more recent trials, adding nuances, sometimes contradictory findings. Rigorous studies like Abidia and Lundahl provided level 1 evidence for persistent healing benefit and reinforced predictive value of baseline TCPO2. However, studies like Margolis, large observational, and Fedorko, controversial RCT, raised crucial questions about real-world effectiveness, potential overuse, impact of inadequate standard care, and challenges of patient selection and treatment completion echoed in Santema. This literature underscores, while evidence supports HBO for select severe hypoxic DFUs within comprehensive care, its use needs careful consideration, objective assessment, and attention to patient ability to complete therapy.
Given this complex landscape, how have systematic reviews and clinical practice guidelines tried to synthesize this and guide clinicians?
Risk notes a large volume of systematic reviews, 2x RCTs. They've evolved with more studies, better protocols, evolving methodology.
Early reviews were cautious.
Often concluded paucity of high-quality research to definitively prove efficacy, healing, or amputation prevention. Called for more rigorous trials.
Later reviews more positive.
As more RCTs included, yes. Reported reductions in major lower extremity amputations, improved healing, or both based on pooled data.
But interpretation varies, the path review example.
Right. Source highlights path as showing bias in how data can be interpreted. Their pooled analysis showed 60% risk reduction major amputation, but p-values differed, RCT 0.29, observational 0.003. Their conclusion remained cautious. Limited RCT evidence, not possible to conclusively establish benefit charms, and no significant effects on amputation rates in the RCT evidence, shows ongoing debate.
Biggest challenge in analysis.
Source emphasizes heterogeneity of patient population across studies, wide variation in vascular status, ulcer age duration, infection severity, inconsistent Wagner grading, makes direct comparisons hard. All DFUs are not equal.
Trying to stratify by peripheral arterial disease presence.
Logical approach. Two 2020 systematic reviews cited. Concluded HBO decreased major amputation but not wound healing in patients with PAD. Had no benefit, amputation, or healing in patients without limb ischemia. The source notes this latter review predated Salama 2019 study on non-ischemic DFUs, which did report benefit.
And formal clinical practice guidelines, CPGs.
Increasingly important. Many general DFU guidelines mention HBO only briefly. Source summarizes several. IDSA 2012. Studies hadn't defined adjunctive role, but reviews may suggest HBO helps prevent amputations. Nice. 2015, UK. Updated to suggest against routine use unless in a trial. IWGDF 2016. Recommend considering systemic HBO, called for more trials. 2019 update, should be considered as adjunct in non-healing ischemic DFUs. SVS 2016. Recommended HBO for DFUs failing 50% area reduction after 4 weeks standard therapy.
Critique of these CPGs.
Source argues they often oversimplify, homogenizing all DFUs, inadequate for nuanced decisions given variations in severity etiology.
Leading to the UHMS CPGs, which tried classifying by severity.
Yes, Undersea and Hyperbaric Medical Society. Comprehensive systematic review used grade methodology. Tried to homogenize literature by DFU severity. Attempted other classifications, TCPO2, vascular infection, but insufficient consistent data.
What criteria could they use?
Able to define 3 distinct populations based primarily on Wagner grade. 1, Wagner grade less than or equal to 2, older than 30 days. 2, Wagner grade equal to 3, older than 30 days. 3, Wagner grade greater than 3, acute wounds needing urgent surgery.
And there are recommendations based on these groups.
3 specific UHMS recommendations, all conditional due to evidence limitations. 1, Recommendation 1, Wagner 2, chronic. UHMS suggests against using HBO. Very low-level supporting evidence. Aligns with studies on less severe ulcers. 2, Recommendation 2, Wagner 1, 3, chronic. For Wagner 3 plus DFUs not improving after 30 days treatment, UHMS suggests adding HBO to standard care to reduce major amputation and complete healing risks. Moderate level evidence. Addresses population with most consistent benefit in literature. Urgi, Fuglia, Londal. 3. Recommendation 3, Wagner 3, acute surgical. For Wagner 3 plus DFUs just had surgical debridement for infection, 2-ray amp, deep debridement, IND, necrotizing infection. UHMS suggests adding acute post-operative HBO to standard care to reduce major amputation risk, moderate level evidence. Addresses distinct acute scenario. Source notes this acute population not explicitly covered by CMS, cost effectiveness unknown, but potential benefit of concentrated course warrants consideration study.
That severity structure provides a much clearer framework. Let's do a mega recap to solidify the DFU section clearly the most studied.
Absolutely. Mega recap for diabetic foot ulcers. We traced from foundational physiology, oxygen's vital role, 325 millimers, acute G thresholds, through HBO's multifaceted mechanisms, O2 delivery, ischemia reperfusion, stem cells, growth factors, to a comprehensive literature review. Saw early studies showing limb salvage potential, how in-chamber TCPO2 became key predictor, how RCTs established efficacy, especially for severe chronic cases and durable healing. We also grappled with challenging studies, observational data questioning effectiveness over use, trials with controversial endpoints, adherence issues, emphasizing HBO isn't magic, selection and comprehensive care are paramount. Finally, examine systematic reviews and CPGs, particularly UHMS grade-based recommendations stratified by Wagner severity. Consensus points towards strong support for HBO as adjunct in select well-managed Wagner 3+ DFUs, chronic failing care or acute post-surgical, while suggesting against use in milder cases. This detailed DFU review sets the stage for analyzing other problem wounds with often less extensive literature.
With that comprehensive DFU understanding, let's look at specific patient selection and treatment protocols for this wound type, drawing from the source.
Source reiterates, consistent theme. Patient selection is the single most critical factor for effective, efficient HBO use in DFUs, simplifies population, those who will heal without HBO, those unlikely to heal even with it, and the target group, those who may heal if HBO is added. Goal is identifying that third category accurately.
And HBO is always an adjunct.
Cannot stress enough.
Yeah.
Always an adjunct to best practices. The voids mnemonic is key. Vascular assessment intervention, offloading neuropathic ulcer, infection control, diabetes control, surgical debridement. Source is explicit. Without these, HBO alone won't succeed.
Timing is critical too.
Needs to be initiated when there's still viable tissue, ischemic penumbra, to salvage. Cannot rescue already necrotic tissue. Shouldn't be delayed if rapid tissue loss occurring.
UHMS guidelines provide the framework for selection.
Clear starting points. Against for Wagner 2 chronic. Suggest for Wagner 3 chronic failing 30 days. Suggest for Wagner 3 acute surgical infection. Clinical judgment always needed for individual cases, but these are evidence-based starts.
Let's focus on that acute surgical Wagner 3+ scenario.
Presented as specific, often urgent indication. For diabetic patient, acutely infected Wagner 3+ DFU needing surgery, partial amp, deep debridement, IND, necrotizing infection, initiating acute post-op HBO suggested if malperfusion hypoxia concerned. Important even if offending tissue removed.
Countering the toe amputation unchecks the box idea.
Exactly. Source explains post-op hypoxia often increases first 3 to 4 days as metabolic demand rises in compromised tissue bed. HBO hyperoxygenates this post-op tissue, potentially reducing complications. Raises question, could a post-op course need fewer sessions if oxygenation normalizes?
For non-acute surgical DFUs, selection still hinges on voids.
Yes. Providers must document optimizing voids factors. Understand HBO alone won't heal. Crucially, source says, inability to normalize all parameters completely is not automatic exclusion if other criteria met and clinical judgment suggests potential benefit.
What about insurance denials for high H-bulk?
Source addresses this. Cites Moffitt review finding no direct correlation between H-bulk and DFU healing. Studies including patients with H-bulk 7.0% successfully healed wounds. Decision should be clinical judgment, overall picture, not solely one lab value.
Objective measures still important. TCPO2 at pressure.
Source reinforces TCPO2 at pressure, 2.0, 2.5 ATA, may be most predictive. Reasonable to measure in chamber, especially if amputation-only alternative. If values suggest low efficacy but no alternative, a trial of 10-15 treatments is appropriate to assess clinical response.
Neovascularization effects seen by 2-3 weeks.
Yes, 10-15 treatments. Lack of clinical improvement correlating with poor TCPO2 findings should lead to stopping therapy.
Actual treatment protocols.
Generally pressures 2.0, 2.5 ATA, 90, 120 minutes length, once or twice daily, 5-7 days week. Acute surgical wounds may need 30 sessions if normalizing. Outpatient usually 30, many need up to 40. Source acknowledges demanding daily commitment. Lundell-Santima showed non-completion rates, 20-35%, but completers had better outcomes. Few need 40, but acceptable with objective utilization review showing progress.
Tell us more about that utilization review process for DFUs.
Necessary, often required by pairs. Performed after initial 30 days or 20 sessions, frequently thereafter. Key elements: document objective wound measurements, presence, absence of progress. Note confounding factors, example, recent debridement, temporarily enlarging wound. Document status of voids efforts, glycemic control, offloading infection. Document rationale plan for further HBO based on progress judgment.
Tying back to TCPO2.
If guided by TCPO2, expect clinical signs of neovascularization by 2-3 weeks. Lack of improvement in repeat TCPO2 measurements should support stopping therapy.
And is observational data relevant here?
Source brings it back. Higher healing in completers, is it because completing therapy causes healing, or because healthier patients can complete therapy while sicker ones drop off? Reinforces need for individualized utilization review, focusing on this patient's progress and adherence, not just population averages.
Very detailed picture for DFUs. Let's move to other problem wounds, starting with arterial insufficiency ulcers, AIUs.
Arterial insufficiency ulcers, another significant category. Peripheral arterial disease, PAD, highly prevalent, 8 to 12 million, US 40, caused by atherosclerosis, aorta, iliac, lower extremity arteries, reduced blood flow, tissue ischemia.
Prognosis is serious.
High tenure mortality, 60%, depends on age severity. Many PA patients develop AIUs notoriously hard to heal, often fail standard management.
Standard management includes
Revascularization when possible, systemic risk factor control, tobacco, diabetes, HTN, HLD, obesity, offloading, infection control, local care, debridement with adequate perfusion. But source highlights. Significant proportion are not REDASCA candidates.
consequence often amputation.
Frequently above ankle amputation, increasing morbidity, mortality. Prognosis varies hugely based on stenosis severity, revasc success. Source gives ranges. With revasc, 43-90% healing, 20% amputation. Without revasc, 40-50% healing, 25-40% amputation.
So rationale for considering HBO and AIUs, especially refractory non-revasc cases.
Considered one potential adjunctive therapy here. Rationale similar to DFUs. Increased arterial plasma O2 drives oxygen into hypoxic ischemic tissue, partially bypassing compromised arterial supply. Provides substrate for healing. Local systemic effects. Increased local growth factors, intero, NO, systemic bone marrow, NO production mass, SBC release, neovascularization. Source notes advanced paid P patients often have decreased NO bioactivity. HBO found to increase NO levels by directly activating NOS, potentially addressing this specific PA deficiency.
What does literature specifically say about HBO for AIUs?
Source notes historical DFU studies often included PAD patients. Hard to isolate true AIU outcomes without diabetes. Raises question of mixed etiology. Wound Healing Society, SUPG mentioned, recommends considering HBO for AIU patients failing after revasc or who are not candidates.
Abor et al. Study focused on AIUs without diabetes.
Yes. Evaluated adjunctive HBO for recalcitrant AIU without diabetes, 82 patients. High-risk group. Failed revasc or not candidates facing amputation. Results. Healing rates nearing 50%, 0% major amputation rate, overall above ankle amputation rate only 17.1%. Source compares favorably to traditional rates for these high-risk groups.
Those results, especially 0% major amputation in refractory AIUs without diabetes, are significant. Patient selection criteria protocols for AIUs.
Criteria. Non-healing despite standard care including successful revasc or evaluation and deemed not a candidate. Protocol. 2.0, 2.5 ATA, 90, 120 minute, once, twice daily, 5-7 days week. TCPO2 use, room air normobaric for baseline ischemia, monoplace chamber. In-chamber TCPO2 can guide treatment pressure, goal therapeutic TCPO2, and identify non-responders.
Utilization review for AIUs.
After initial 30 treatments, frequently after, similar to DFUs. If initial in-chamber TCPO2s suggest low efficacy but amputation-only alternative. Trial of 10-15 treatments reasonable to assess clinical response. Lack of response by then should discourage further HBO.
Moving on, calciphylaxis.
Calciphylaxis or calcific uremic arteriolopathy. Rare, extremely serious, often life-threatening, painful skin lesions, chronic non-healing ulcers, gangrene, underlying, small vessel calcification, etiology unclear, strongly associated with end-stage renal disease, ESRD, on dialysis, 1 to 4% prevalence, increasing incidence.
High mortality.
Very high, 60-80%. Often from infection sepsis of lesions, pathogenesis, calcium deposition in media of small dermal subcutaneous arterioles, hypovascularity, fibrosis, dermal necrosis. Most common lower extremities, but can be anywhere. Incredibly painful.
Given calcified hypovascular tissue, rationale for HBO and calciphylaxis.
Straightforward. HBO delivers oxygen at high pressure, increasing arterial plasma O2, driving oxygen into profoundly hypoxic tissue affected by calcified narrowed vessels. Hyperoxygenation promotes neovascularization, collagen deposition, potentially improving perfusion and healing.
What does literature say about HBO for calciphylaxis?
Available treatments varied, address metabolic issues, stop oral calcium, non-calcium binders, lower dialysate calcium, parathyroidectomy, sodium thiosulfate. Mortality still high. Source notes promising results with adding sodium thiosulfate and/or HBO.
Evidence mostly case reports.
Primarily case reports and few retrospective series, no RCTs. Source highlights examples. And et al., 34 patients, AVG 44TX, varied outcomes. Podemo et al., 25 resolution, improved TCPO2. Bazile et al., 811 healed. Arenas et al., Dawn et al., successful cases. Specific cases detailed. ESRD plus DM patient responded after failing other therapies. CIPD patient responded after 38 HBO.
Promising results with thiosulfate plus HBO together.
Yes. McCulloch et al. 25 patients receiving 20 HBO-TX also got thiosulfate, had a resolution. Baldwin et al. 67 patients recovered with multi-interventional approach, including both.
Based on this, patient selection treatment protocol for calciphylaxis
May be considered, given high morbidity, limited options. Biopsy recommended, but multidisciplinary clinical consensus acceptable. Protocol: 2.0, 2.5 ATA, 90, 120 minutes, once, twice daily, 5-7 days a week. Source emphasizes minimum of 20 treatments, shorter course unlikely effective. Recommends patients also receive sodium thiosulfate concurrently to potentially maximize benefit.
Utilization review for calciphylaxis.
After initial 30 treatments, frequently after, key point. Patients getting subtherapeutic number, 20 sessions, unlikely to benefit based on case series data. Progress, rationale documented.
Next, graft versus host disease, GVHD-related ulcers.
GVHD, significant complication after allogeneic stem cell transplant. Donor immune cells attack recipient tissues. Cutaneous issues common. Pruritus rash, development of chronic wounds mediated by donor T cells.
Chronic GVHD, similar to autoimmune disorders.
Pathologically similar. Often leads to local tissue damage, dermal subcutaneous endothelial damage, microangiopathy, local tissue ischemia, fibrosis, Buerger's difficult chronic wounds.
Rationale for HBO and GVHD ulcers.
Twofold. First, addresses tissue hypoxia from microangiopathy fibrosis. HBO delivers increased O2, promotes neovascularization, collagen deposition. Second, potential immune modulation role given GVHD's autoimmune features. Studies suggest HBO might reduce damaging lymphocyte proliferation, modulate inflammatory cytokines involved in GVHD itself.
What does literature say about HBO for GVHD, especially wounds?
Sources states literature is limited. Mentions one 2008 animal study showing improved survival, reduced lymphocytes inflammation in mice with induced acute GVHD treated with HBO versus immunosuppressants.
Human data.
Source highlights one published case report, patient with bilateral non-healing ankle ulcers from GVHD. Normal macrovascular studies, but TCOM showed significant local hypoxia, 223 mHg room air. Oxygen challenge suggested responsiveness, 641-121 literal OHG 1 ATA O2. Received 60 HBO treatments, 2.0 ATA. Achieved successful healing.
Based on limited data like that, selection criteria protocol suggested.
Based on limited evidence, consider for non-healing GVHD ulcer failing standard care. Objective oxygen assessment important. Room air normobaric TCPO2 for baseline ischemia. 40 mmHg impaired. Source states in-chamber TCPO2 200 mmHg required to continue, indicating likely response. If 200 at 2.0 ATA can increase pressure, 2.42.5 ATA to reassess. If still 200, further HBO not recommended. Protocol, typically 2.0, 2.5 ATA, 90-20 minutes once, twice daily, 5-7 days a week.
Utilization review for GVHD.
After initial 30 treatments, frequently after. Document progress, objective rationale, likely TCPO2 response, clinical improvement for continuing.
Let's move to venous stasis ulcers, VSUs.
Venous ulcer disease, incredibly common, dominates lower extremity ulcer differential up to 90% of chronic LE wounds, chronic non-healing ulcers from lower extremity edema, frequent in older outpatients, typically medial lower leg malleoli areas of dependent swelling.
Edema causes.
Various. Venous incompetency, heart failure, renal failure, liver failure, often bilateral, certain meds, calcium channel blockers, NSAIDs, GOX2 inhibitors. Venous incompetency, usually unilateral or worse one side due to valve dysfunction.
Prevalence.
Estimated 1.53 per 1,000 population overall. 1 to 2% lifetime risk. Increases significantly 80 years old, 20 per 1,000.
Appearance.
Irregularly shaped medial leg malleolus, associated skin changes, pigmentation, can be painful, usually less than ischemic ulcers, often maceration, exudate. Source briefly reviews normal venous physiology, muscle pumps, one-way valves return blood, prevent high pressure reaching skin, fails in venous insufficiency, chronic venous hypertension ulceration.
Given prevalence, what does literature say about HBO for venous stasis ulcers?
Source reviews several studies. Hammerland and Sundberg RCT 8 HBO8 sham, trend towards smaller wound area with HBO, but not statistically significant at 18 weeks. Healing rates also NS Kranke-Cochrane Review 2005, included trial of 18 VSUs failing 1 year, concluded insufficient evidence for HBO effectiveness versus sham. Andrade et al. 2016. Included 42 VSUs reported significant healing due to HBO, but source notes no specific rates quantitative data published.
This rigorous study, Thistlethwaite 2018.
Yes. Randomized, double-blind, placebo-controlled trial, 31 patients, chronic VSUs, 1 IR, hypoxic TCM responsive to oxygen, 30 treatments, HBO 100% O2 2.4 ATA versus validated sham error 2.4 ATA. Primary outcome, healed at 12 weeks, no statistically significant difference. Secondary outcome, percent area reduction HBO group did show improved PAR, 94% PS, that's 54% at 12 weeks.
So, similar pattern.
Okay.
Might speed up area reduction, but not necessarily complete healing within the study.
Appears so, based on evidence presented. Despite 2 trials showing increased PAR, the rigorous Thistlethwaite trial showed no difference in overall healing. Therefore, source conclusion: insufficient evidence to recommend HBO for routine VSU treatment currently. Standard care compression remains cornerstone.
Utilization review for VSUs.
Since insufficient evidence to recommend treatment, UR specifically for this indication is not warranted.
Next, wounds related to scleroderma, systemic sclerosis, SSC, Raynaud's RP.
Systemic scleroderma, SSC, complex autoimmune connective tissue disease, abnormal skin thickening, collagen accumulation, progressive small artery damage, localized, hands, face, or systemic includes organs, underlying autoimmune dysfunction, collagen overproduction.
Pre-hypoxic environment.
Yes. Deposition restricts blood flow, impairs healing so-crew, causes wounds, often digital ulcers. Infection risk further reduces oxygen.
Rationale for HBO and SSCRP wounds.
Addresses hypovascularity, delivers increased O2 to hypoxic tissue, promotes neovascularization, collagen deposition. Also, potential immune modulation role, as SSC is autoimmune. Studies suggest HBO might reduce damaging lymphocyte proliferation, modulate inflammatory cytokines involved in SSC.
Literature for SSCRP wounds.
Source states clearly, mainly case reports, detail several. 1967 series, 6 women, HBO, 2 ATA BID, reported symptom improvement, skin mobility, faster ulcer healing, pain relief. 1976 Korean case, HBO for skin contraction. 1991 abstract, observed improved outcomes in collagen disorders, including SS granos, no data. 1997 negative case, large leg ulcer failed, HBO needed surgery.
More promising reports.
Yes. Marcus et al. 2006, complete healing in 2 SSC patients, digital leg ulcers, 30 HBO TX, 2.4 ATA. TC on confirmed ischemia, showed improved perfusion post-HBO. 2013 Greek case, complete healing in tractable toe ankle ulcers, SSC plus RP. 34 HBO TX, 2.4 ATA, prevented amputation. Marin Review 2014. Found only Marcus cases, concluded some effectiveness, limited data. Source notes Chinese, retrospective, 90 SSC patients, 2.0 ATA, reported 91.1% significantly improved. Poirier 2017, complete healing refractory toe ulcers, 30 HBO TX, 2.5 ATA, alternative for failed therapies. Marisoglu 2017, Turkey retrospective, 6 SSC patients, digital leg ulcers, 4 healed completely, 2 nearly, none required amputation. Fans 41 HBO TX, Sato 2018, Japan, complete healing painful digital ulcers, Raynaud's just 10 HBO TX, 2.0 ATA, Can 2020, Japan, successful treatment necrotic fingertip, diffuse SSC, refractory pins, 30 HBO TX, 2.0 ATA, Ahejan Lana 2020, Spain series, 4 women, SSC RP, complete digital ulcer healing, 34, reduced Raynaud's frequency severity, all 4, 30 HBO TX, 2.4 ATA.
So lack of controlled trials, but multiple case reports suggest benefit, often preventing amputation. Selection protocols.
Based on case reports suggesting potential benefit, consider for non-healing SSCRP ulcer failing standard care. Crucially, no randomized controlled studies validate HBO as standalone treatment. Weigh risks benefits carefully. Approval needed prior, often used refractory cases. Typical pressures 2.0, 2.5 ATA, up to 30 sessions reported.
Utilization review for SSCRP.
After initial 30 treatments, frequently after, document progress, rationale acknowledging evidence level.
Next, sickle cell ulcers, SCUs.
Sickle cell disease, SCD, genetic disorder, abnormal hemoglobin, HBS, causes red cells to sickle, especially low oxygen, impairs circulation, vaso-occlusion, ischemia, pain crises, organ damage, anemia. Lower extremity ulcers, known complication, but source notes paucity of literature specifically on treating them. Prevalence 2.5% in SCD patients. Other SCD ischemic issues, pain crisis, have been treated with HBO.
Rationale for HBO and SCUs or other SCD issues.
Core idea. Low oxygen triggers sickling. HBO raises PO2 significantly, potentially reducing sickling potential. Laszlo, 1969, first showed this. 2 ATA lowered circulating sickle cells, while in 1985 animal study, HBO increased IPO2, reduced sickled cells in rabbit hyphema model.
Contrary finding.
Michalski, 2001 in vitro study, suggested HBO did not directly affect sickled cells in vitro, implying other in vivo process accounts for clinical effects.
Clinical literature on HBO for SCS-SCD complications.
Largely case report small series for various complications. Dysphagia Swang, 1966 negative series. 6 patients, pain crisis, no improvement, though circulating sickle cells decreased. Reynolds, 1971, first reported successful treatment sickle cell crisis, abdominal, rapid pain resolution with HBO, 2.0 ATA. Freilich, 1973. Scleral buckling procedures done under HBO prevented anterior segment ischemia. Sterneman, 2012. 9 patients, vaso-occlusive crisis, reduced pain scores, analgesic use with HBO, 2.5 ATA. ASIC 2012, successful treatment refractory priapism, 11 HBO sessions, 2.5 ATA. Canon 2014, successful treatment central retinal artery occlusion, SCD, significant vision improvement after 20 HBO sessions, 2.5 ATA.
But limited specific data on sickle cell ulcers.
Exactly. Case reports for various vaso-occlusive events suggest potential benefit, especially when conventional therapies fail. But source states clearly, no randomized controlled studies validate HBO for SCD, crises, or related wounds. Weigh risks benefits. Approval needed prior. Typical pressures 2.0, 2.5 ATA. For wounds, up to 30 sessions reported.
Utilization review for SCUs.
Acknowledge variety of reasons for HBO and SCD. Each has own rationale. For wound care, you are generally after initial 30 treatments, frequently after. For other issues, treatment length should correlate with symptom severity.
Finally, pyoderma gangrenosum, PG.
Pyoderma gangrenosum, PG, rare destructive neutrophilic dermatosis, skin subcutaneous. Clarification. Initially thought bacterial, not currently believed infectious, can occur independently, 50%, or associated with underlying pathology, 50%.
A ton of associations.
Inflammatory bowel disease, UC, Crohn's, arthritis, gammopathy, Takayasu's arteritis.
Apparent.
Distinctive, deep ulcer, well-defined violaceous blue undermined edge, surrounding skin red, indurated, starts small papulopustule, breaks down ulcers, cat's paw appearance, coalesce. Central necrosis, most common legs but anywhere. Painful, often severe, depth varies, serpiginous enlargement, late stage. Atrophic cribriform scar, defining aspect. Pathogy, new lesions reactivation at trauma surgery sites.
Histop.
Edema, dense neutrophil infiltrate. Small medium vessel thrombosis, surrounding hemorrhage. Neutrophil inflammation, abscess, naphthalene liquefaction. Vasculitis-like features possible.
Rationale for HBO and PG.
Similar to other hypovascular conditions, inflammatory thrombotic process knock tissue hypoxia, HBO delivers increased O2, promotes neovascularization, collagen deposition. Also, as PG is autoimmune inflammatory, potential immune modulation role. Studies suggest HBO can reduce damaging lymphocyte proliferation, modulate inflammatory cytokines.
Literature on HBO for PG.
Source states HBO successfully used for decades as part of multimodal regimen. Detrone 2007 review cited positive and negative studies, overall consensus. HBO is effective treatment, note cessation of pain, improved quality of life, suggests use for severe recalcitrant cases.
Summarizes key cases.
Yes, from Detrone review. Cases by Thomas Jr., 1974, Furman, 1975, Wyrick, 1978, Davis, 1981-85 pre-grafting, Wassertail, 1992, Fitzpatrick, 1997, Jacobs, 2000, Nizgonu, 2006, Masokopakis, 2011. Consistent theme, challenging PG refractory to conventional meds, steroids, immunosuppressants, showed significant improvement healing with added HBO as part of multimodal plan. Common outcomes: rapid pain reduction, less inflammation, halted new lesions, successful closure, sometimes enabled grafting.
Recent cases mentioned too.
Briefly mentioned Sato 2018, Can 2020, Aishan Lana 2020 involved similar vasculitis inflammatory ulcers, showing potential benefit, further supporting consideration in complex inflammatory wounds.
So similar pattern. Evidence, mainly case reports, but numerous over decades, suggesting benefit within broader approach.
Precisely. Multiple case reports suggest potential benefit, but states clearly, no randomized controlled studies validate HBO as standalone treatment for PG, weigh risks benefits. Often used as part of multimodal regimen, PG needs comprehensive medical management. Approval required prior, often used refractory cases. Typical pressures 2.0, 2.5 ATA, up to 30 sessions, common in reports, some needed more.
Utilization review for PG.
After initial 30 treatments, frequently after. Document objective clinical progress, wound, pain, adherence to overall medical regimen, rationale for continuing HBO based on response.
We've covered a tremendous amount today. Foundational science to specifics of multiple wound types and the evidence for HBO in each. Let's bring it all together.
We have indeed. Started with that diver observation, delved into foundational physiology, oxygen's role, thresholds, explored HBO's multifaceted mechanisms beyond just O2 delivery, ischemia, reperfusion, stem cells, molecular signaling.
And systematically reviewed evidence, application selection, protocols across the spectrum. Major focus on DFUs, where evidence is most robust but complex.
That systematic DFU review provided the framework. Limb salvage studies, RCTs, CPGs pointing towards HBO as adjunct in severe, chronic, or acute infected Wagner 3 plus managed comprehensively, then applied that lens to others. AIUs, promising in select refractory cases, calciphylaxis, case report support, often with thiosulfate, GVHD ulcers, limited but suggestive reports, VSUs, insufficient evidence, SSCRP wounds, Numerous case reports suggest benefit, often preventing amputation. SCUs, reports for complications, limited for ulcers. PG, decades of reports support use in multimodal regimen.
Really underscores value of approaching each wound type individually.
Absolutely. Systematic approach essential. HBO isn't one size fits all. Evidence strength type volume varies dramatically between diagnoses, reflecting unique pathophysiology and how HBO mechanisms might interact.
Bringing us back repeatedly to critical importance of patient selection and adjuncts.
Perhaps the most vital takeaway across all indications. Proper patient selection, often guided by objective measures like TCPO2 where evidence supports, is paramount for effectiveness and efficiency. And HBO must always be viewed and used as an adjunct within comprehensive standard care, addressing all underlying issues. Voids for DFUs, revascularization control for AIUs, medical management for inflammatory conditions, etc. Without that foundation, HBO alone unlikely to succeed.
Ultimately, balancing available evidence with clinical judgment for the individual.
The reality of complex medical decisions. We have trials, efficacy, observational data, effectiveness, limitations, systematic reviews, CPGs. But applying that to the individual patient, their unique presentation, comorbidities, wound specifics, goals, ability to commit requires sound clinical judgment informed by, but not dictated by, the evidence. Constant balance.
This has been a truly deep dive to leave you, our listener, with something to ponder. Given the significant cost of hyperbaric oxygen therapy and the questions raised about real-world effectiveness, treatment completion, and maybe suboptimal selection and observational data, how can clinicians and systems best ensure this powerful adjunct, where evidence supports it, is delivered not just safely and effectively, but also efficiently and equitably to the specific patients truly most likely to benefit, really maximizing its value proposition?